This is ANA Investigates. Last year, the FDA approved adaptive deep brain stimulation, or adaptive DBS, for the treatment of people with Parkinson's disease. This is a major step forward in neurology. It allows personalized therapy by adjusting DBS settings in real time based on an individual's brain signals. Our guest today is Dr. Helen Bronte-Stewart, the Johnny Cahill Family Professor of Neurology and Director of the Human Motor Control and Neuromodulation Lab at Stanford University. Dr. Bronte-Stewart was interviewed by Dr. Karlo Lizarraga, Associate Professor of Neurology and Director of the Motor Physiology and Neuromodulation Program at the University of Rochester. If you're anything like me, you'll come away from this interview with a much better understanding of how this technology works and what's coming next. So here's Karlo.
Welcome, Helen, and thank you so much for joining us today. This is an honor for me. I still remember when we first met at the annual meeting of the ANA in 2015. I was a neurology resident, and I was working on a DBS project with Dr. Cornelio Luca at the University of Miami. And he was really kind to introduce us. I was really starstruck when I met you.
Karlo, that's very kind of you, and thank you for having me on the podcast.
Yeah, thank you again. And for our listeners who may not be familiar with DBS, could you briefly go over the basics of deep brain stimulation and its indications for people with Parkinson's disease?
Yes, absolutely. I often talk about DBS, or deep brain stimulation, as a brain pacemaker. We can also call it a deep brain computer interface, or a DBCI. And really, what DBS consists of are chronically implanted electrodes which stimulate neurons and axons in strategic nodes in brain networks and modulate the neural activity locally and downstream in the widespread connected network. The deep in DBS refers to the location of the electrodes for DBS for movement disorders, as they're placed in deep regions of the brain called the basal ganglia. And so in Parkinson's disease, we place the DBS electrodes in the basal ganglia regions that are part of the sensory motor network, with a goal of improving motor and some non-motor symptoms. And we're now extending the possibility of DBS and Parkinson's disease to modulate other networks like the cognitive and limbic networks. But for the sensory motor DBS, these circuits are what we call dopaminergic, meaning that they're influenced by striatonigral dopaminergic activity. Of course, as we know, dopaminergic medication also influences this circuitry in the basal ganglia. So a key indication for DBS for Parkinson's disease is that the person considering DBS should have a good motor response to dopaminergic medication. And the degree of the response to medication predicts the degree of response to DBS. So that's a very important part of the candidacy, is then you need to do a very careful off medication evaluation and in the person's best on medication evaluation to determine that they actually are responding to medication. However, there are some carve-outs to this situation, such as medication refractory tremor in Parkinson's disease, which actually responds to deep brain stimulation. And the other real carve-out is that some people get motor response complications such as dyskinesias when they're on medication, and that limits the dose that the neurologist can use with them or that they tolerate. But otherwise, apart from that, that is the strongest indication. One of the major contraindications, as we know, is if somebody has dementia. Then, unfortunately, we are worried about making that cognitive impairment worse.
Thank you very much, Helen. And so we know DBS works, and it has been around for almost 4 decades, actually. How exactly does adaptive DBS work, and how is it different from standard deep brain stimulation?
Yes, well, one of the abnormalities in Parkinson's disease in this sensory motor network is that there is a development of what we call exaggerated neuronal oscillations and excessive neuronal synchrony. And I often refer to this, along the brain pacemaker analogy, as a brain arrhythmia. And that effectively jams sensory motor processing in this network and leads to motor impairments such as bradykinesia and rigidity. A useful analogy is that normal, what we call broadband neural activity is like the hum of people talking, say in a cocktail party or a restaurant. One can still carry on one's own conversation with a neighbor. The brain arrhythmia in Parkinson's, on the other hand, is like a crowd chanting the same thing over and over again and blocking any other type of conversation. Both DBS and dopaminergic medication reduce the amplitude of this brain arrhythmia. However, the degree of reduction of the brain arrhythmia is very important. So just like glucose or blood pressure in diabetes or hypertension, you don't want to be over or under modulating this biomarker of PD. And for decades, we have been using DBS with dopaminergic medication, both of which reduce this brain arrhythmia, but we don't monitor it or measure it during therapy. So you can imagine we could get into difficulties when medication kicks in and there's an overcorrection of this arrhythmia, and when medication wears off and there's not enough correction of this. So the difference with adaptive DBS is we now can measure the brain's neural activity directly from the implanted electrodes and implanted battery or pulse generator during the therapy. And we can now use the degree or strength of that brain arrhythmia to drive or adjust the strength or the amplitude of DBS. Thus, we stimulate only when and to the degree that the brain needs it.
Thank you. That was an awesome explanation. And what type of brain signals were chosen for adaptive deep brain stimulation, and why were those signals chosen?
Yeah, there's been a lot of research that's gone into this with a lot of people over several years. If we think about the brain, it transmits information within and across networks in different frequency bands. This broadband neural activity is similar to a broadband communication system. The greatest capacity for information processing along multiple domains at the same time, such as movement, speech, cognition, emotion, etc., is if the system can use multiple bands at once, transiently synchronizing different connected brain regions in certain frequencies or coupled frequencies. The problem in Parkinson's disease, as we said, is that that motor network gets locked in the brain arrhythmia that I mentioned. And this is a normal brain rhythm in the 13 to 30 hertz frequency band, which we call the beta band, that would be normally transiently synchronizing, and we call that bursting, over the broadband activity for less than about 150 milliseconds at a time. In Parkinson's disease, these bursts get prolonged up to over 2 seconds, and that's how they jam the normal sensory motor processing in the motor network, which leads to the PD symptoms. So as I said, we and others have done a lot of work to demonstrate that the beta band overall power and these prolonged burst durations are actually pathophysiological features in Parkinson's disease. We've shown that when we apply DBS at high frequencies, we can attenuate or lower that beta band power and reduce the burst duration in a dose-dependent manner. And the degree of attenuation is correlated with the degree of improvement in the motor signs such as bradykinesia and rigidity. And I call this finding relevant neural signals, which we can now use as inputs for adaptive or closed-loop deep brain stimulation. So once these first investigational sensing neurostimulators were available, we can sense power in the beta band directly from the implanted pulse generator, feed that through our control policy algorithms, and then adjust DBS amplitude based on this beta power input, thus keeping beta band power within a stable therapeutic range, not too high, not too low, just like glucose and blood pressure. So with this, we developed what's called the dual threshold adaptive DBS algorithm that used beta band power to control DBS amplitude. And we used this dual threshold so that we really allowed the system to increase amplitude when the beta band power went above the upper threshold, but then to leave it steady when it was in between these thresholds and only decrease the amplitude when it went below the lower threshold. Some people have called it the thermostat approach. That is being used now with a sort of long adaptation, what we call ramp times, to really match that long duration of medication-induced beta band changes, and precisely with the idea of how can you use these two therapies together to really keep that beta band power in that therapeutic range and just modulate it gently. Now, you can also use what's called a single threshold mode, which uses a more rapid ramping up of the stimulation intensity and ramping it down again. So we now have these two modes we can use, both of which are now approved, but they may work in different ways. So we've also gone ahead and developed what we call kinematic adaptive deep brain stimulation by using real-time kinematic measures of movement, such as gait, such as using wearable sensors, to adjust either amplitude or frequency of deep brain stimulation based on that direct behavioral input. And this has successfully treated gait impairment and freezing of gait. Now, other signals in other frequency bands are also being looked at, such as cortical gamma signals to treat dyskinesias, theta band, and dystonia. So we've started with this, focusing in on this beta band, which is really a very strong pathophysiological feature of Parkinson's disease. But now we're beginning to look at other signals in other bands.
Wow. Thank you for that explanation. One of the most exciting aspects of this for me as a clinical neurophysiologist is this integration of individualized neurophysiological data into a well-established model of care in DBS, which is team-based patient care. This is very exciting, and perhaps our listeners from other fields will be inspired. What are the challenges that DBS providers are facing as they now implement adaptive DBS in their clinical practices? Do you have any suggestions to perhaps overcome those challenges?
It definitely is a bit of a learning curve, but really it's just like when we all started doing deep brain stimulation itself. There's a learning curve, but there's really just a couple of extra steps. So if you do programming for continuous open loop DBS, your amplitude is going to stay the same. Now in adaptive DBS, the amplitude is going to be modulating, and this is the way the clinical adaptive DBS now is doing. They're adapting amplitude only. So in our research, we were adapting frequency, but that's not a feature yet. So first things when you set people up is, do they have enough beta power that you can record from the implanted lead in order to drive the system? So if you have too little power, it's not going to be able to drive the system, and there are clear thresholds as to what's enough and what's not. Then the most important thing to do is, okay, I need to make sure that my DBS amplitude fluctuates within therapeutic ranges. So not too high so that the person doesn't get side effects, and not too low that it's not therapeutic. So then you want to make sure you have people stay around so that as the system is, you do some streaming. I usually walk people around the clinic and we see how they do as it adapts. Now, remember, in the dual threshold algorithm, it's going to adapt very slowly. So you're not necessarily going to see it. But when you do the single threshold algorithm, Peter Brown and Simon Little, way back when in the first paper that they published in the Annals in 2013, made this comment that the system had to adapt from a lower limit all the way to an upper limit and then back down to a lower limit in a kind of trapezoidal fashion enough times so that the person didn't actually feel the sensation of the ramping up and ramping down. And that's become what we call the duty cycle. And it's really interesting. If you don't, the person can feel the amplitude increasing, and they can often get lightheaded or get paresthesias. So it sounds complicated, but it's actually not. It's very straightforward, and it's just like any new therapy. People get really good at it.
Thank you very much, Helen. I've heard many of your talks, and you mentioned consistently that you think that DBS is underutilized in the United States. And we know that access to DBS can be limited not only in the US, but also worldwide. In fact, as part of an international exchange program, I have evaluated people with severely disabling motor complications that are resistant to every medication change they have available. And I do also know from my own experience that DBS could work like magic for them. But I also know that DBS is just not an option for them. And do you have any suggestions to manage this medication-resistant motor complications for people who do not have access to DBS? And if you have any comments about, as clinicians and researchers, what can we do to improve access to DBS in the US and also worldwide?
Yeah, it's such an important point. I may take the second point first. Consistently, about 12 to maybe 15% of people with Parkinson's disease get DBS. There are several problems. And of course, the traditional problem was that somehow this perpetuated through the field that this was a treatment of last resort, which I think we know now for any kind of neuromodulatory therapy is the opposite. People would tend to be referred once they had chronic non-dopaminergic motor and cognitive problems, and basically it wasn't going to work. So I think that we've got to shift our understanding that, like cardiac pacemakers, this is a adjuvant therapy that can help restore normal rhythms and do these very concrete things in motor networks, and then be used judiciously, as we're talking about, with medication to stabilize that network. The other problem, I think, is there are a lot of people who don't really want to have wires in their brain. It's an invasive procedure. And we have to really work with our patients, obviously not to do it if they don't want it, but also to try and help people realize that even though this sounds really invasive, it's actually a very finely tuned procedure done very safely all over the world for many decades. So, it's not for everybody, but I think as a field of neurologists, we should be thinking about when to refer people and be very careful that we're not limiting that therapy until it's too late. Once people are beginning to experience these motor response complications, wearing off, dyskinesias, unpredictable on-off fluctuations, that's the time to refer them, because that you could really either almost avoid or really take them back in many years so that you don't have to deal with that. Now, let's just say you haven't been able to refer them to DBS, they haven't been able to get it, the country doesn't offer it, etc., etc. What do you do? Well, the first thing I would say is that right from the get-go, when you're treating the person, you try to delay the onset of motor response complications by the use of long-acting strategies. You encourage the person to try and stick to their medication regimen. You do all the things you can to avoid what we know can hasten the onset of dyskinesias. And then, now that we have focused ultrasound, I think this is very helpful for tremor. So there are other things we can do these days, but I think one of the things we can do is really try to help refer people for this potential therapy when they're still candidates and not wait too long.
Thank you very much. What are the most exciting areas of active and future research in the field of DBS?
Wow, lots. I think we're just at the beginning of device-based therapy using this network and circuitopathy approach and taking advantage of the brain's structural and signal characteristics to modulate networks in different ways. For instance, we used to always think we had to put these in nuclei, but now we're targeting the nucleus basalis of minute lateral efferent bundle, so a fiber bundle, because the nucleus itself is not really a very appropriate target to vertically place a DBS lead in. But if you grab this fiber bundle that exits the nucleus basalis with a directional electrode, so with a steering, you can really modulate that efferent bundle. And now it's very interesting, I think, in OCD, is there's an awful lot of discussion that all these different targets for OCD are actually like little side roads and entries into the great highway of information, and you're actually accessing more of these large fiber bundles. In depression, Helen Mayberg has really been leading this field, showing us that you can modulate different pathways, different fiber bundles, and actually affect different forms of depression, different symptoms in depression. And now, of course, we're also being able to use what we call pattern stimulation. So this is also investigated, it needs an IDE. But now, for instance, in the nucleus basalis, based on the primate work that David Blake and his colleagues have done, we're using pattern stimulation only on for 1 hour a day, because we're not trying to get rid of that brain arrhythmia. We're trying to kind of restore synaptic health, blood flow. So we have to use it in a different way. So there's an enormous amount of work going on now in where we stimulate, how we stimulate, when we stimulate, and for what. Tourette syndrome, you have a motor problem and you have a mood problem. So you access both networks. So now we're doing multiple leads. We're crossing networks. We're not just using one network. And that's, I think, where this is just going to continue to expand and be very exciting.
Wow, this was great, Helen. Thank you very much for sharing your insights with us today. And thank you for leading the DBS field forward. I look forward to seeing you soon, and perhaps at the next annual meeting of the ANA.
Well, thank you so much, Karlo, for inviting me to this podcast and having this chat, and look forward to seeing you soon in person.
That was Dr. Helen Bronte-Stewart of Stanford University, interviewed by Dr. Karlo Lizarraga of the University of Rochester. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Sarah Nelson and Sharon Ellen Govan. I'm Adeline Goss, podcast host and executive producer. producer. Our production team this month included Karlo, Lizarraga, and Helen. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates.